So good morning. Thank you for choosing to spend your time with me here. I know I've been involved with the Perform Better Summits for well over 15 years at this point, first as an attendee, and then I started speaking, I think, all the way back in 2010, which is insane. And in fact, I haven't been back to this one since 2018, so super excited to be back here in Long Beach. But today we're going to talk about Achilles. And the first thing that I want to ask you guys before we get started, how many of you have had your own Achilles injury of some kind, rupture, tendinopathy, some kind of thing? Raise of hands if you're willing to share. How many of you have worked with or rehabbed somebody that has an Achilles injury of some kind? Plenty more. How many people know somebody personally who's had an Achilles injury of some kind, right? It's a really common thing. But surprisingly, that's actually not why I chose to pick this topic. It was my own personal experience as an athlete and then also working with individuals, just seeing it, and I knew I didn't know enough about it, and I wanted to dive into it. And so what started as what I thought would be a culmination of months of diving into the research and education and sharing that with you guys became this launching pad to so much information and so much unknown that's still out there that exists. And so there's so much exploration. And so what I've tried to do is at least try to pull things together in a way that will make it actionable for you so that you can leave here no matter who you are, no matter how long you've been in the field, understanding that this comes from my perspective as an athlete and as a longtime strength coach, scope appropriate. There are certainly other things that are appropriate for Achilles injuries, but they are outside of my scope of practice, and so I don't really touch on much of that in here. But I wanted to give you things that you can do to help try to mitigate risk if we possibly can. We certainly can't eliminate it. Things are going to happen. But as I've really dived into this, there is a lot that we can do, and there's a lot that many of us are missing. There's a lot that I was missing in my own training for myself, even with coaches that worked with me. And so now I'm trying to add that back in. So it's kind of a little bit selfish in that manner. So I've broken this out into a few different areas. We're going to dive into a little bit of the science. We're going to talk about the tendon physiology and adaptation and recovery and what it takes to actually stimulate that tendon to do what we want it to do, talking about what risk factors go into it. I am not going to stand up here and tell you that I know why Halliburton tore his Achilles tendon. We can't do that. There are so many things that go into it, but if we start to identify what some of those are and start to work on bringing those up to what they need to be, we can maybe help. Might not be able to stop it, but we can at least improve, right? We're also going to be looking at not just people who are already injured, but trying to prevent that from happening, okay? So through that, we're going to go into some assessment protocols. We're going to look at what can we do as strength and conditioning coaches, fitness professionals, maybe some of you are clinicians, again, outside my scope of practice, but what can we do to identify some of that stuff? How can I test somebody to know what's happening for them? What can I do to then train some of those factors that I know I need to bring up? So we've got progressive load strategies and then actionable training methods that you guys can take with you and implement when you leave, okay? So first thing I want to get into is, why does it matter? Why does it matter? We think Achilles is attached to explosive athletes and NBA and all of these people who do really explosive movements. But what does the Achilles actually do? It took you here today as you walked over here, right? The Achilles transfers force. It doesn't only transfer explosive force, it transfers all force. So when things happen, it has a really big impact. And it happens to a very wide range of people. It's not just the narrow audience of explosive athletes. And so it matters. It matters to a lot of people. So that's the role in movement, right? What does it do? What did I put on here? Sorry, guys. I want to make sure I give you all the stuff. So it's all the, yeah, I did get to that. All the locomotion, when it fails, everything stops, right? When this doesn't work anymore, that affects a whole lot of things, and we're going to talk a little bit about that. So let's go into the incidents. So just by the show of hands, you guys saw almost everybody either has experienced it, worked with somebody, or knows somebody that has Achilles injuries. And guess what? They continue for a long period of time and have a very large impact. And the incidence is growing. So it is something that is just, over the last number of decades, more and more and more people are having this problem. And that's due to a lot of different factors. But if we as an industry have the ability to help mitigate that, then we should do that. And so we should figure out what we can do to make that happen. So just alone this year, there were 7 ruptures in the NBA, and many of them just in playoffs alone. That's crazy, right? But it's not just basketball. I only grabbed gymnastics partly because that's who I am. I was a gymnast for many years. At the Olympic trials last year, multiple elite athletes went down with an Achilles rupture. And these are just the ruptures, right? The tendinopathies and the other stuff also is persisting and increasing. There's a lot of things that can go into it. They do talk about some of the things like playing surface and playing time, maybe early specialization in sport, which gymnastics has always been. But our landing surfaces are changing. They're becoming a little bit more compliant, which is supposed to help like even out the load, but there are some things with compliant surfaces that put more stress on the tendon. They're also throwing bigger skills than they threw before, right? So but again, it's this very cloudy area of, we can throw a whole lot of ideas as to why these things are happening, but that's all we have. But if we can at least attack some of the factors that do contribute, hopefully we can make a difference. So what's the effect? Obviously, it's an injury that has long-lasting effects. If you have a rupture, or you know someone that ruptured, you know it is a very long recovery, very long. They say, estimate to come back to training at full force, 11 to 12 months. It's more like 2 years. And even then, a lot of people don't come back to their previous performance at all. There's, a forever change in that tendon. So these are some stats that as I got into the research, a lot of people in professional sport who have access to the best training, the best rehab, the best doctors, still don't come back, ever. And if they do come back, they don't come back to the same level that they had been before. Doesn't mean nobody does, but it's not the average. And even if they do come back and are able to perform and they're able to continue to play, they often have a shorter playing career overall. So there's a lot of stuff that happens. And for somebody who is earning their living as an athlete, that's a big deal. It's a big deal for the team who loses a star athlete that they're paying, right? So it's financial loss even on that side of it, right? There's a lot of pieces of it. So finally, it's personal perspective. So as a strength coach, again, I wanted to know what I could do better. And so I wanted to dive into this. But also, as an elite athlete, right? I was an athlete over 4 decades. I was a gymnast. I started at 18 months old. I did Division I college gymnastics. Yes, I'm tall now. I used to be 4'10" when I started high school at 80 pounds. I became a strength coach out of school and became an Olympic weightlifter. I did a couple of Olympic trials. I transferred over to the bobsled world and traveled with them for about 10 years on the World Cup tour. And then I threw some Highland Games. So I've done many, many, many explosive sports, which also means I've had many, many, many teammates in those explosive sports who have had Achilles ruptures, Achilles issues, either during or after their athletic career. And so that's always in the back of your mind as an athlete, thinking like, when's that going to happen? Well, Yep, that's me. I bet you're wondering how I got in that situation. I had retired at 38, and I had spent however many years afterwards, I don't know if it was 6 years, something like that, not doing a whole bunch of anything. However, as an explosive athlete, I still had lots of strength and power, and I loved gymnastics, and I had done a handful of training sessions. Certainly none of the stuff that we'll look at today. And I decided to go to an adult gymnastics class. Because I could, and I was capable. And that's one of the problems, is I could get away with it until I couldn't. And I didn't necessarily do anything wrong. I didn't land wrong, but I was doing all of the sins of Achilles risk. I went in and I was in super dorsiflexion on an angled mini trampoline, which is like this. So I was in very big dorsiflexion, leaning over onto a surface, doing a bounce to handstand drill, which I was totally capable of doing. And I did about 5 of them before I landed, bottomed out, and blew both Achilles tendons at the same time. The nice thing is it was not painful. And because I knew so many other people who had done it, I also knew that was going to be the next year of my life. There were a lot of other things that happened at the same time. We don't need to go into all that, but it made things more challenging. But so that was me. And by the way, I always put my dogs in my pictures because at that time I had 8 and I was in a wheelchair for 8 weeks and my significant other was out of town almost that whole time. So it was a lot of fun. But they took care of me, which was great. But so this was kind of a little bit of my recovery, right? This spanned like 8 months, okay? That last picture, that's a high jump. I had a 32-inch vertical, sorry, 32-inch vertical, not 42, 32-inch vertical. That was my jump at 8 months. I could barely leave the ground. It is a long, long, long recovery. And so diving into this topic was very selfish for me because I wanted to learn what I should have done differently. What could I have done to prevent that? I now understand a lot. And we'll talk about that as we get into some of this stuff. But I put myself in the worst possible position, and we see a lot of people, I see a lot of people who are living that same life. And if we can do something to educate, to train, to help yourself, that's what I want to do. And I've got lots more to learn, lots more science to dive into. The nice thing is a lot of the recent tendon research is at least they tend to agree on most things, which is really interesting. There is a shift in what the original gold standard was to what kind of we're looking at now, but it doesn't negate some of the other stuff. There's a few different personal opinions on some things for training. So as we get into some of the details, number one, please forgive my very, very cardinal sin text-heavy slides. I wanted to provide you the information so that you could take it with you and then go from there. Normally I like to do slides like this that are nice and pretty, but there's just so much information. And like I said, as I started diving in, I really thought I was gonna get to the point where I was like, here you go. This is what we do. And instead, it's kind of like, okay, here's a lot. Here's some things you can do, but there's a lot more to go if you were interested in doing more from there. Okay? So, this is you guys. If you are training people, individuals of any age, or if you're working with athletes, or maybe you're a clinician, you are in a position to help. You're in a position to take the steps that might help prevent what happened to me, what happened to you, what happened to your friends, what happened to your other people that you've been working with, or at least make it a little bit less of a big impact, right? Because what do? We see our people a lot for the most part. depending on who you are, most of the people in our industry see people on a very regular basis, sometimes multiple times a week. So you're able to see a lot of what might be happening before it actually becomes a problem. Just like a lot of other things that we do. So if we can do that, I want to give you some systematic screening things. So what do you need to look for? So we're going to talk about what you should look for when you're working with people. How can you assess somebody? How can you assess their risk? Then you are in a position to control and manage their load. You will see that load is the overarching, most important piece of tendon health, especially for Achilles tendons. Tendons love load. And in traditional history, we tend not to load them very much because they're sore, or that's not the rehab protocol, but tendons love load. And what do we do in our industry? We load people. And there is a very fine line between too little and too much. And so it's learning to navigate that, and that's hopefully what I'm kind of giving you some guidelines on. But we can mitigate that load for people. We can manage that. And then you can be the person that bridges rehab and performance. If you are a clinician and a coach, great. But if you're not, you should be working with somebody who is a clinician if you are a coach, and vice versa, so that you can understand both sides. And if you have an athlete or a patient that is seeing somebody, you should be able to communicate and adjust what you're doing based on what they know. So what is the Achilles tendon? I think everybody basically knows it's at the back of your lower leg, right? Attaches your calf to your heel. It wraps underneath the heel, right? But what I didn't know until I started diving into this is that it's actually a twisted structure. Did you guys know that? The Achilles actually is twisted as it goes from your calf into your heel, and that's part of what gives us that spring. Also interesting is when you've had a rupture, especially if it was in the middle portion, you now lose that rotation. So how much does that affect how your return to play, right? So just some pieces that I was not aware of. I mean, all of us have been through anatomy and physiology, so we're kind of generally familiar with the Achilles tendon. There is also what's called a watershed area. So we'll talk a little bit about tendon injuries and where those happen, but the watershed area is a portion of the Achilles that's not at the heel, it's kind of in the mid portion, and that's actually where it rotates, and that's where your decreased blood supply is, and that's where your most common injury is. So it's just something to be aware of and understand that. There are also other, and when we talk a little bit about injuries, there are some other anatomy pieces in there. So there's the paratendon, you've got some other pieces in there, you've got bursa that can also be affected by some of these things. We're not going to address those, but just kind of bring them up that they are there. So what does it do? Just like we talked about, it brings you everywhere. It's locomotion, right? It takes me from here to there. It allows me to do everything I want to do, whether I'm walking with a cane or doing explosive gymnastics. That is what it's going to do for me. And it also obviously can work like a spring, or it can just transfer force, right? Both are transferring force. One is just basically transferring slow force. The other one is energy storage. So as I put load into that tendon, it stores that energy and gives it back to me. And so what does that do? That's what we're going to use in all the explosive activities, right? So that's what improves performance. The more energy storing capacity I have in my tendon, the more explosive I can be, the faster I can be. And so we want to be able to retrain those things, because a lot of that is lost with Achilles injuries as well. So we want to make sure as we look to our training strategies, we're addressing all of the needs of what that tendon needs to do for us. So it's going to be individual too. pretty much everybody needs the same pieces because you are going to have some type of energy storage, but the degree to which you need it is going to change if you're an elite gymnast versus a 60-year-old recreational athlete. But everybody needs it. There's also, oh, and then I just gave you some stats on the amount of body weight. Think about this with load. So when you're walking around, maybe you've got 2 to 3 times of your body weight into that tendon, right? When you start running, jogging, you get 4 to 7 times your body weight. Think of how much weight that is. You know how much you weigh. Multiply that. That's what's going into your tendon. Why do you think load is so important when we start training these things? Like body weight alone is not going to be enough, generally. And then for most people who are even a high-level athlete, we're at about 10 to 12 times body weight. That's a lot of weight. If you're a gymnast, they're seeing loads of 15 times, now they're tiny, but 15 times your body weight. They're coming down from heights of like 10 feet and landing. Like, it's insane the amount of force that goes through the ankle and in that tendon. And so we have to keep that in mind when we start thinking about training. Because if I need to prepare somebody to be able to absorb that much load, my training better support that, or else I'm leaving them at risk, right? It doesn't mean I'm taking 10 to 15% of load and using it, but I can do what I can to help them do that better. And then what we call stiffness. I want to make sure I kind of touch on this just a little bit. If you come from the track world, if you come from anywhere where there's a motion of getting out of the floor quickly, that's what we refer to as stiffness. So it's stiffness in the tendon, and it's the tendon's ability to act like a spring really, really, really well and really quickly, right? That's a stiff tendon. It does not mean lack of range of motion. So stiffness is not somebody who can't get into good dorsiflexion, because we actually want both. Stiffness is a functional thing, not a static piece. Does that make sense? So we want to train for stiffness. We also want, if there's a deficit, we'll also train for mobility, but we definitely want to train for stiffness. Very, very important. So when we talk about tendon adaptation, like I said, so we've got your collagen architecture, load and energy storage. Waiting for a tendon to heal, this remodeling of the tissue, way slower than muscle, way slower. And the approach to training a tendon is different than how we train a muscle. There are a lot of similar parameters that go into it, but the actual way that we target the tendon is going to be different. And that's what we're going to talk about a little bit as we get into the training strategies. So the recovery from it is super slow. Waiting for tendons to heal is kind of like waiting for Avatar 3 to come out. It takes a really, really long time. But if you like Avatar 3, it's worth the wait, right? Or if you like Avatar, waiting for it is worth the wait. Load is the key stimulus. That's going to get us everything. Everything we do is going to be centered around load and our managing of it. And the nice thing is, even though some of this might be new for you, managing load is something we do all the time. So if you just understand the parameters and you understand the goal of what we're trying to achieve, you can take the knowledge you already have and apply it using some of the tendon science and start bringing this into your own training and with yourself and with your clients. I just wanted to make sure I mentioned there are other factors, right? And that's why a lot of this stuff is such a cloudy thing. We can't say for sure why somebody got injured. Because if somebody's not sleeping, if somebody has poor nutrition, we already know all that stuff, right? Like, that affects everything we do. It affects tendon health as well. So I just wanted to make sure I highlighted on it, because of course it affects it, but we won't talk anything about it. So we've got this Goldilocks principle of load management. In order to change the tissue, if we're training muscle, we need to challenge it. Same thing with tendons. If we're gonna try to change tendon tissue, we have to challenge it. So we can't have too little, right? We can't be afraid of loading a tendon, and that includes, in many cases, in most cases, an injured tendon. It includes a painful tendon, because if we're not doing it, we're not going to improve it. Now, there are a lot of caveats to that, of course, and if you're not in the medical field, there are certainly, and we'll touch on it, times you need to refer out and work with the professional, but we understand this. Too much load, same thing, too much is also a risk of failure. That's also a problem, right? So we have to find this just right place. But the crazy thing is, nobody can pinpoint it, and it's individual. So I might take one person with these tendon concerns and these environmental concerns, and they're the same athlete, they're the same age, so many of the same parameters, and they will have a different response to another person that on paper looks just like them. And so a lot of this is going to be individual. And we see that with other training as well, of course, but just keep this in mind as you go into this. There's no like on paper exact right way to do it, which is why I say as we get into the training pieces of this, they're guidelines. And if you want to learn more, I'm certainly happy to talk. I'm still learning. I can also put you in the right direction from some of the people that I'm learning from. But you got to keep this in mind, because we got to find that for everybody. So there's this tendon continuum. We need to put little damage into the tendon to change it. That's the challenge. But this is kind of what happens as it gets worse. So that degenerative is when it gets chronic and we really start having issues. The disrepair is when we have this breakdown, structural changes are happening. The reactive is just like, that's a little too much. Back off, you're still fine. But just to kind of know, this is how the tendon starts to have problems. Now what's interesting is, too much too fast is not always recognized by pain. It may be other symptoms, other risk factors that you should probably start to see in some of your assessments. Usually by the time pain happens, the damage has already started. And so keep that in mind too. We may already be in the disrepair stage by the time our tendon starts hurting. And so we're already at a point where we're kind of at a deficit. Here's when we start to get into all the text heavy stuff. Sorry guys. We don't have to go through all of it, obviously. But this is your timeline, okay? When we start to look at how a tendon heals, do you see how long that is? 6 to 24 months, depending on the damage to the tissue. 24 months, and that's from what might have been a healthy tendon, right? So the first 2 weeks we're in this kind of acute inflammatory stage, and then from 2 to 6, we're starting to put new tissue down, we're starting to improve. Hopefully we see some symptom improvement, hopefully we see some performance improvement, functional capacity. But then we're still working on that thing to 24 months, and that's just for healing. So if my tendon takes that long to heal, you know what I want to do? I want to prevent that from happening in the first place. And so we need to, even after tendons are healed, right? Or even for a healthy tendon who hasn't gone through this, we need to start doing this with everybody so that we can hopefully put everyone in a better position, help them heal faster or at least more completely, and also work on people who don't yet have problems, at least that they're aware of. So again, just like I said, slower than muscle tissue, 100 days for collagen renewal. That's a long time, right? Just keep this in the back of your mind. Tendons are slow. And again, back to the pain idea, pain is not an indication of a healthy tendon. So we might go through some of the proliferation and start getting some symptom relief, and we're like, I'm good. But we're still in disrepair. And that's the real danger zone when somebody's like, man, I feel good again. I'm gonna go do the stuff I wanna do, right? But they still have deficits. They still have risk factors. And so if we have a complete comprehensive toolbox and we're looking at all of that stuff, then we can help them understand with some education. We're all in the education business, right? If we're working in the fitness industry, we're always educating. So the other thing is also with tendon recovery, we need 48 to 72 hours in between loading. You might feel fine, but the tendon is not ready to accept it, right? So some parameters that are going to be different from muscular loading. So let's talk a little bit about the injuries. Like I said, in that watershed area, that's that mid portion. So if we have, so those top two, mid portion and insertional, mostly apply to tendinopathies. So that's kind of a blanket term for tendon injury. That's not a rupture. And then of course you can have complete or partial tears of your Achilles. Now we have some other things down here, and I put them on here because just for you to be aware of, you might have pain in the Achilles area that actually is one of these other things. So the paratendon is the sheath that goes around the tendon, and that can be irritated for various reasons. The plantaris is back there. It can have some tendon issues. The superficial bursa is between your tendon and the skin. That can give you heel pain, similar to what you would feel for an insertional Achilles tendinopathy. So where that tendon comes down around the heel is insertional tendinopathy if it's the tendon that's affected. And there are different ways you can kind of start to tell. I mean, obviously that's a clinician's role, but if you start to at least be aware of some of these things, you might be able to say, oh, this could be another issue. Maybe you should go see somebody, right? Maybe it's this, right? So there are some guidelines on some of that stuff if you ever want to dive into it. But just know that there are other things back there that even if they have what feels like might be tendon pain, it might be coming from something else. So to talk a little bit about tendinopathy, it's pain and in damaged tissue. That's the main thing. And there's deficits in functional capacity. There's reduced load handling. So if you train, you might have a different, a worse response to training than you have with a healthy tendon. So you start to notice some of these things, but just to understand that like tendinitis specifically is an inflammatory condition, and that's usually just in those first 2 weeks. And so if we're trying to attack an injury and we're trying to help somebody improve and we're using anti-inflammatory tools, we may not make any progress if we are beyond that first 2 weeks, because it's not inflammatory, it's damaged and it's deficient. And so we have to think through those things as well. So again, back to the pain versus pathology. So I'm sure you're aware of, imaging in your back. You do imaging of people's backs, and you've got all of these, oh, we've got disc issues, and we've got this, and we've got that. And some have pain, and some have never had pain. Tendons are the same way. So just because you've done imaging on a tendon and it's damaged, it does not mean that it's painful. It means that it's damaged, but it does not mean it's painful. And just because you have pain, you may not have the damaged equivalent to your level of pain. So separate that. There's a whole rabbit hole to dive down if you want to start learning about pain science, but it's not indicative. And the things that trigger pain are actually not the same things that trigger the damage. So they're actually slightly different. They can be related, but they're slightly different. So to understand that piece of it. So we've got 4 tendon myths. So often you think, and this again goes back to the inflammation. We think it's inflamed, I got to stay off of it. But what did we say earlier? Load is what tendons need. Now we need to know how to load it, but load is actually what we need, not rest. A lot of people think, oh, it feels tight, it feels stiff, I got to stretch it. But it's not actually a mobility issue. So, and like I said earlier, you can have that sensation of feeling stiff, but if you've tested the range of motion and there's not actually a mobility problem, stretching probably isn't going to help. And stretching without load won't help anyway. So we need that load. Calf raises are typically what's prescribed for most of those issues, tendon issues. I mean, you certainly do them. We are going to utilize them, but they're not enough by themselves. And we'll get into that with some of the training. And then again, back to the imaging. Imaging does not tell you anything. It tells you the state of the tissue. And maybe there's some pieces you can gain from that. But overall, that's not going to be your guiding tool for what you need to do for your individuals. So remember, controlled progressive loading. Okay? Because that's going to be our theme through our whole talk today. So this is what I was talking about when people start to try to pinpoint, why did that Achilles tear happen? But do you know how many risk factors and contributing things there are? And we're going to go into, I've actually split this out into some different risk areas that you can start to look at when you're working with people. But here are quite a few. And usually when something happens, an acute injury happens, there's a whole bunch of stuff that happened, right? Because we have things like biomechanics, surface considerations. So take Halliburton, for example, who's just the most recent one that was in the media. He had a calf strain a couple days or a couple games before the game where he actually tore his Achilles, right? Any injury like that alters your biomechanics. It alters your capacity. Now, some people are going to say, oh, he did it because of his calf strain, but how much did he sleep in between those games? Did he overuse the tendon by playing in the game in between, right? There are so many other pieces, like sure, the calf strain probably is a contributing factor. Is it the main factor? Probably not, because he may have strained his calf for the same reason he tore his tendon, right? Like the calf strain is just a different injury. But a lot of the same pieces may have gone into that. And it's usually, and that's why I put it at the first one, a quick, aggressive step back. So if you think about what's happening in that movement, right? They step back, so it's explosive. They're going into a pretty extreme dorsiflexion. You're asking the tendon to be stiff and act like a spring. And I'm also in hip extension. The glute is actually a big contributing factor in glute function to how the tendon works and and the capacity. So there are so many pieces. That's why that particular movement, and I have many teammates. So as a bobsled athlete, we spend a lot of time out on the track. And I couldn't tell you how many of my teammates did the exact same movement that they had done so many times. And one time, that was enough things together that just made it go, right? So that's why there's so many cloudy things. We're not going to be able to pinpoint it. We're not going to be able to say, this is what happened. And I think in the media, you hear a lot about, non-contact Achilles injuries. Most Achilles injuries are non-contact. It's not like the ACL. It's not usually, you don't tear your tendon because somebody landed on it. You tear your tendon because of the forces you're putting into it and asking it to do something. Now, sometimes, sure, there's contact involved, but the majority of tendon tears for the Achilles tendon are not going to be contact injuries. So don't listen to the media on that piece. Okay, so I've put this into 4 different risk areas that you can use to continually monitor yourself and the people you work with. So go into why it matters. We've already talked about that. Again, move beyond it just happens. Achilles are just going to tear. I can't tell you how many days when I did things after I retired and I knew so many of my teammates had torn their Achilles tendons that I was like, man, I'm at risk to tear this thing. Did I do anything about it? No, because I didn't know any better. So now I am trying to do better. And there are a million things in this risk profile that would have put red flags all the way around me and put me in a bubble because I was not in a position to do the loading I was asking my body to handle. Muscularly, sure, that was no problem. But connective tissue, not at all. So we want to be able to recognize patterns. We want to be able to kind of keep it in the back of your mind when some of the risk things that you'll see in here pop up, because they're not all going to be present when you first scan somebody. So these are things you're going to revisit on a regular basis to make sure that you're covering your bases. So here are your 4 areas. So these are the areas we just kind of want to keep in our mind. And I've given you, I've given you some very specific ways to start looking at some of this stuff. But some of them we can't change. I can't change how old you are. And I'm sorry to tell you that if you're over the age of 35, you are at greater risk for tendon tear. I think I was 44, 43, something like that when I tore mine, right? There are hormonal fluctuations. There are previous injuries. I can't change any of those things. I can't do anything about that. But I, when working with somebody professionally, should be responsible to find these things out so that I can kind of keep in mind, oh, they're at a greater risk, right? And how many other factors are going to go into it? How many other risk factors do they have? And how much emphasis do I need to place on this because of the risk factors I'm seeing, right? Extrinsic factors. So these are things often we can change. We've got environment and surface and shoes and some of that stuff. Our load history, again, this is huge. Changes in load are going to be a big difference. Recovery periods. And then your movement quality, your biomechanics. So stuff that we should be doing on a regular basis, some of the movement assessments. We want to start to do some very Achilles specific and contributing issues, some scans for that, so that you can be a little bit more well-versed in what you're seeing and what we need to do. So for intrinsic factors, here's your list. We don't necessarily need to go into all of them right away, but women, you get to be a little bit older before you're at a bigger risk, according to the research studies. But men between 20 and 39, but you're seeing tears in young kids, gymnastics. Average tears, the women's gymnastics has 10 times more Achilles ruptures in the NCAA than any other sport. And those kids are not older than 22. So you're seeing it in young people. Other contributing factors, so obviously, people who are have metabolic issues, so diabetes, if you have a large body frame, like these are all contributing factors, right? Some of them we can work with, right, and can help people on. But there's hormonal things. So for women who are perimenopausal, the change in estrogen levels also affects your tendon health. And even through your cycles, where you are in your cycles. I mean, that's deeper into it, but just to know that is a risk factor, okay? And then again, previous injuries, because again, those affect a lot of stuff. Guys, so many words, I'm so sorry. That top, I think, says surface areas. So interestingly, hard surfaces can be a problem because it creates more tendon strain with the same amount of force. But compliant surfaces can also give more tendon strain. So kind of like that load continuum, we've got to find where that load is. So if you have recently changed which surface you're on for sport, maybe you're on one field one day and then you're in the parking lot doing something or on the track or whatever, just the surface difference and what your Achilles has to do might be enough to trigger a problem. And then footwear, that might be enough to change a problem. So you have people who, you've got track and field athletes who maybe early in the season are in just regular running shoes. And then they're ready to start to go into spikes. Well, guess what? That changes how the tendon has to work. And that can be enough of a difference. So like you've done all this stuff, you think you're ready, you're at the right point of your season, but that change could be the trigger that puts it all together, that ends up, putting you over that hump and gives you that injury. Other stuff in there, I'm gonna mention at the bottom, some of the medications. So if you have somebody that is on a fluoroquinolone who just starts it, there is a very high injury risk, tendon tear, like rupture tear, with being on that. And then a little bit less with corticosteroids and contraceptives, but there is a lot of research supporting that. So like something to be aware of if you have a client that's taking that, and maybe make some different choices with what you're doing with them. So here are your dangerous patterns. So those were the areas to kind of look at with extrinsic factors. And like, here's some things. If we're going, so load history, I want to have progressive load. So if somebody just took 2 weeks off, and even if they're an in-shape athlete, if they're coming back after 2 weeks off, that's bigger than a 10% weekly increase in load, right? So I have to keep that in mind and maybe temper that first week back for somebody. Cumulative stressors. So take into account what they're doing outside of their time training. Are they someone that is, walking hills? Are they walking the beach? Are they putting more strain on that tendon outside of your training time or outside of their practice time? Because if so, we need to account for that. We need to know how much load is going into that tendon. And they lose their capacity quickly. And that, I used to do this mindset, that was me, right? That was 100% me. Also, post-break return, more than 2 weeks, probably 6 years, right? I was capable, my body was not. And I didn't feel incapable because I didn't know how to test for it. So movement quality. You guys hopefully are at least semi-familiar with doing some movement testing of some kinds. A lot of those things are going to come into play. So foot function, ankle function, glute function, and how they all work together, all of that affects what that strain is on that tendon. And if those are not as functionally sound as they could be, the tendon might take more strain than it should be required to for the same amount of load, right? So I do want to look at some of that stuff. I'm going to talk about asymmetries a little bit here. So asymmetries, I want to make sure I put the caveat out there. If you have an athlete that is a one-sided sport and they do a lot on one side versus the other, they're going to have an asymmetry. That doesn't necessarily mean that they're at risk, but I want to monitor that asymmetry and see if there's any change to it. So if they normally have this amount of asymmetry and then now all of a sudden they have this amount of asymmetry, or they become even for that matter, it's going to kind of just like put my little spidey senses up and I'm going to go, okay, what's going on? And so then I'm going to use some of the other testing to kind of figure out, okay, what happened here? What are we looking at, right? Okay. Man, I don't know why this is so high. Sorry, guys. Okay, so what can you do? So we've got those 4 domains. Now I'm going to give you some actionable tools that you can take and start using to actually apply this stuff, right? So we've got to track, assess, monitor, reassess, adjust our training, and repeat, and rinse and repeat, and rinse and repeat, right? Okay, this is what I wish I knew. Because a lot of my issues that contributed to me tearing both Achilles at the same time would have been modifiable. And doesn't mean I wouldn't have ever torn them, but I probably could have mitigated my risk. Education is key. We've got to talk to our people about some of the tendon science and understanding how much load we actually need to put into that tendon based on what they need. So if you have an individual that runs for long distances, the amount of load per step might not be as high, but if they're running a marathon, that's a lot of load over the course of time. So I better build some capacity, right? And so if you can start to bring that together for somebody to understand what you're doing to help them, usually that increases your person's willingness to comply, right? Self-evaluation is often inaccurate. I am 100% a representative of that. So just because they say, and again, this also goes back to that pain thing, like, I feel good, I'm ready to go. Am I though? I better look at some of these the other screening things before I actually make that decision. Again, load management, systematic screening, and then multiple risk factors coming together. Okay, so here are our screening strategies for you guys. Number one, since we are not clinicians, maybe somebody in the room is, but I am not a clinician, I better know when I need medical clearance. And I would err on the side of caution. I would rather have more input from somebody who knows a lot more than I do about those things than less. So I want to make sure I put that out there because I want to stay within our scope, because I am talking about some things that somebody might hear and say, oh, I can diagnose this. Oh, this is this, right? But we probably need a lot of help as well. So I'm giving you some guidelines on what we can do when we know enough. Sometimes we need to know more. There are tools for subjective reporting. So yes, there are some issues with relying on subjective reporting, but when you put it into the whole pool of things, it's going to help. And I'll give you some of that. Functional testing, I'll give you some very specific things. And then again, movement history. So hopefully we know when to refer out. Obviously, if somebody has a rupture, we need to send them out. That is nothing that I'm going to handle. But if you're working with someone and they're not seeing symptom improvement, they should probably go see somebody. Night pain, there's times when tendon pain can be acceptable because our overall goal is not necessarily to get somebody completely out of pain, it's to get that pain managed. And so there's kind of, again, this fine line that we're always walking between like, ooh, is that too much? I don't know. Okay, let me see what I can monitor. If I don't know enough, here's this person you can go talk to, right? So again, coaches and clinicians. So here's some tools for subjective reporting. There is a questionnaire. You can find it online. It's very easy to find. And it literally just asks you about your experience in life. Like, can you do this? Do you have trouble walking? Do you have trouble doing these things? It's just subjective. And that's why it's not diagnostic, it's just tracking. So I'd like to see if over time somebody starts to have different responses. Again, that's gonna raise my spidey senses to go, oh, I better kind of keep my eye out. What else am I seeing? Am I seeing other deficits in performance? I obviously want to, and we should be doing this anyway with everybody we work with, but I should know injury histories. I should know if they've got any of those other changes in there, especially related to kind of this stiffness and pain and deconditioning and missing activity. Those are not just at the beginning, these are things I need to be aware of all the time, right? So I just need to ask questions more often. Okay, that's your visa A. Just a little bit about that. That'll be in the slides. That's fine. So let's jump into functional testing. These are just some examples. These are not your gold standard of like, this is all you're going to do. If you choose to join me this afternoon in our hands-on, we will do some functional testing in there. And we'll do more than this. We'll look at some mobility things. We'll look at some Achilles functional and capacity things, and then also some related things. So, but these are just for you guys to make sure that you have a starting point to start to go, okay, here are some of the things that we're looking at, right? I wanna make sure somebody can do a single leg calf raise. There are going to be, when we start talking about training strategies, there are some kind of standards that I need somebody to be able to make in order to implement the next training strategy or a particular training strategy. And so some of this will help guide what I use based on that individual's capacity, right? So I wanna know things like, how can they do 25 single leg calf raises? And yes, there are kind of some parameters around it, but generally, can they do 25 single leg, full range of motion calf raises? You know how many calf raises I could do when I went to that gymnastics class? Probably 2, because I had not, and my history is, I also, in addition to all my Achilles stuff, I had my right ankle reconstructed when I was in college, And then when I was bobsledding, I tore the anchor out. So I have no TFL on either side. I have no ankle stability. I had a strained calf when I was a bobsledder. I mean, my lower limb history is really long. And yet I was doing none of this stuff. I had some coaches that had me implementing some pieces of the training strategies, but had I been doing more of this stuff, I would have been in a better position. So, and here's the other thing, is the other reason that I dove into this topic is, even though I did this back in 2019, I can still, right now, maybe do 3 on one side, because I have not spent the time training it. And so the more I dove into all this stuff, the more I was like, oh my gosh, I am in big trouble right now, because my number of risk factors are like glaring, and it's crazy. So there's a hop testing battery, so both bilateral and single leg. They're different things with quality, and you can go for time. There's all kinds of pieces. Jump rope is more capacity. And some of these are, you're gonna see like, do they hurt the next day? All of that stuff. I'm not gonna dive into specifics because there's so much of it, but I wanted to give you some idea of it, and then you can start looking into this a little bit more yourself. And again, we'll do some this afternoon. And then all of that is going to guide my adaptations based on what I'm seeing. Also, outside, well, those were all tendon related, right? I'm also going to look at foot and ankle. I'm gonna look at hip, hamstring, core, glute. All of these are contributing factors. You can see on the bottom right how those things affect the strain that goes into my tendon. So I need to make sure I'm looking at all of this stuff, because if I have somebody that has a weak glute, or maybe they've got a lack of hip extension and they're trying to go back into that step back that we talked about, that's a problem, right? So all of this stuff comes together. So now we've got our training. So let's talk training. The gold standard used to be eccentric load. So, go up, down, slow, calf raise, for example, right? That was the gold standard. It still works. But some of the more modern, recent tendon science is now starting to uncover why that worked, and also guide us in other directions for different individuals based on the parameters of their individual situation and their individual injury, right? So isometric is first. And part of the reason for that is isometric is the lowest fatigue, basically. Even if you go super heavy, it's still lower fatigue than a heavy eccentric. And we're going to get into all of these, but we've got isometric, so holding a specific position, and again, we will do some of these in the hands-on today. We've got eccentric, so always was what was prescribed before, still useful, but there are some times when it might not be the best choice for somebody. Heavy, slow resistance, this is the newer piece. As they've really started to understand what factor load plays in tendon health, this has become a really, really big portion of strategies for training tendon durability and health. And part of that has to do with what made eccentric training work well was the time under tension. So if we can do heavy, slow, isotonic, concentric, eccentric movements, we also have a lot of time under tension. Now there are times when you can load an eccentric more, so it might be better to get a greater load for an eccentric, but heavy, slow, that's the key point, slow resistance training is a really key part of training for durability, because what does that tendon and ankle have to do when we do everything else? Right? So the first two start to build some of that capacity and the patterning and the strength, and then working through the heavy, slow resistance kind of bridges you to actual performance. And again, performance is me walking down the street, right? That's my Achilles doing its job. And then everything else from there. And then finally, we need that, like we talked about in the beginning, we need that tendon to be able to be reactive. And so we need to train it. And we can, if you, a few years ago, I did my talk on power training. And I talked a lot about power training for seniors and how important that is. Because a lot of people kind of, oh, they're 60 years old. They shouldn't be doing any of that stuff. There's a lot of stuff they should be doing, and there's a lot of times they need it. And so everybody moves into that reactive training in some capacity. So again, lots of text, sorry guys. But the things I want to highlight on this, number one of the kind of benefits of isometric loading, so holding a position. Now mind you, holding that position is not just go up to the top of my calf raise and stop. I might load that through the whole range. I need that load in many different positions. There are times when I don't want to go into dorsiflexion. So depending on the person, if somebody has insertional tendinopathy, when you go into dorsiflexion, so if you're doing a calf raise on a step, for example, and your heel goes below the step and you're into that dorsiflexion angle, you actually get a compressive load on that tendon. So not just the load from you weighting it down, but you get a compressive load from that tendon pushing into that heel. And if you have insertional tendinopathy, that can be aggravating. And so doing isometrics out of dorsiflexion is where we start. So we actually start in like mid-range, maybe up a little higher. You can train any part of that position because we need to be strong through all of it, right? And eventually bring some dorsiflexion in. But notice if you try to implement some isometrics in a dorsiflex position and somebody, or if you're doing some of the other stuff and you're in that dorsiflex position and that's what triggers more pain, then isometrics can be a great starting point. And for a lot of people, they can be analgesic. So you can do some isometric loading on a painful tendon, and that tendon will actually feel better. Now, that day. Now, did I change the qualities of that tendon as far as capacity or tissue? No. And that's why you always also have to keep in mind pain and function and tissue damage are totally different. But there's a whole psychosocial piece of this too, that if somebody has a painful issue in their body, that causes a lot of problems. So if I can give them something where we can mitigate that pain, that's going to be huge. And I'm working on increased tendon loading. I'm working towards the whole continuum of getting them stronger and ready for more stuff. So who you use it with, people who have acute Achilles pain, people who have flare-ups later, so it's pain management. Also, remember, it's lower fatigue. So if you're working with athletes and they're in season, or somebody who has a lot of tendon load throughout their week, maybe you're not going to do heavy slow resistance training that week and you're going to go back to isometrics. So there are a lot of parameters that you got to think about, but almost everybody should be able to do some form of isometric. Okay. The other thing I want to highlight is this creep and stress shielding. There's two different pieces. So stress shielding, I'll talk about just briefly. As you get damage in your tissue, the rest of the tissue is still strong. And because it's strong, it likes to take over. And so the strong part of your tissue shields the weak part of your tissue, which is sometimes partly why you still feel fine, even though you have a damaged tendon. Right? So that's stress shielding. And some of the heavy slow resistance and isometric, this is one of the places where some of the research differs. Some people say you can't train the damage, you're just laying down new tissue and then in strengthening the good tissue. Other people have said that you can actually, with some of this training, actually target some of those weak areas. And so then it stops stress shielding and allows it to completely start working through the whole tendon again. So that's one place where things are a little bit different. But the other piece is creep. So longer holds. So let me say this and actually I think I say this on the next one. So protocols, we don't need to go into them, but just know that sometimes we're going to do really long holds. I'll say 30, 45 seconds. Sometimes we'll do 6-second holds. So a healthier tendon is going to benefit from heavier, shorter loading because it's not necessarily going to need the analgesic piece. It's not going to need this creep piece that we're going to talk about. So creep is when you are holding that position where the muscle is pulling on that tendon for an extended period of time. Over time, the tendon starts to relax and the muscle starts to contract more. And so that allows that tendon to have a better response to that training. So an injured tendon will usually benefit from longer isometric holds. And even if you have a healthy tendon, it's not a bad idea to build capacity. But those are two pieces, and so that's creep, tendon creep. Eccentric training, again, all I want to say about this is, like, again, all of this is here for you guys. You can pull the slides up later. I wanted to give you the information because, like I said, as I started diving in, I'm like, there's so much. I just want to give it to you all. But obviously, we can't dive into everything in a 75-minute talk. But remember that eccentric training can be aggravating to people with painful tendons. So maybe start with isometric and progress to the eccentric. So that's kind of the continuum. But also consider alternatives if you've got an acute injury, insertional tendinopathy, or you're unable to do it without pain. So if you can't perform it without pain, probably a good idea to do something different. But it's the time under tension, which is why then, and again, some of this stuff, but that's why this heavy, slow resistance has now become kind of, this is a really big part of tendon training. Again, at the top, you've got similar outcomes to people who are doing eccentric training, and it progresses you more completely to reactive training, because you have to move through a full range of motion, right, for reactive training. So I need that concentric strength as well as the eccentric strength. And so this is going to train both. So some people might just skip eccentric training completely. Depends. If you can jump right into this without issue, awesome. Like, it's a great way to start to focus on tendon training for people. I want to get through all this stuff. You guys can look at that later, just some guidelines. And then moving into plyos, remember, that tendon is built to work like a spring. If you have tendon issues, it is less stiff, it's more compliant, it's not functioning the way that it should, so we want to work towards this. But remember, way back at the beginning, we said too much too soon is going to start causing tendon issues, and tendon recovery is long, tendon healing is long. So this is included, but this is like way down the line. And especially if you've had a seriously injured tendon, a rupture, you're not going to be doing much of this stuff for at least 8 months, generally. Okay? There may be some ways to do it, and there are some bridges to get there, just like there are with most training things. If we're trying to kind of take the step up to the next level, skill level, and something that has greater requirements and greater demands, there are some bridges to get there, right? So I'm not just going to go from a heavy calf raise into, like, you know, drop depth jumps or something. You know, there are bridges, but we do want to increase that, get people back to that again. So some parameters on that, things to monitor, some of the things you can use. I mean, if you've done any education in the training world, you've probably seen progressions for plyo stuff. It's going to be very similar, because at that point we've now hopefully got a relatively functionally good tendon that has capacity and able to handle some of that stuff. We do have to think about recovery in between, but that was true anyway before, right? So that's always been the case. So here's your kind of progression. So in the very beginning, if we have a painful tendon, we've got to decrease the pain and start to increase capacity and teach patterning. So we've got to teach that tendon to do what it's built to do, right? Or retrain it to do what it is built to do. So from there, so that's isometrics. From there, we go into increasing strength. Now I've got to get that tendon strong. And I can use eccentrics. I can use heavy, slow resistance training. We talked about some of the differences. And I want to now start to go into that dorsiflexed position. In the beginning, we're usually avoiding that, especially, again, for insertional tendonitis. But I want to start to train that, because when I walk forward, what is my back foot doing? It's in dorsiflexion, right? So I need to make sure that I can train a tendon to be in a position that somebody needs to use. Now, the amount of dorsiflexion somebody walking needs versus somebody who is in like a bobsled, for example, where we're in a super low position and the shin angle to the ground is very, very sharp here. Like, that's way more than I need to just walk across the floor, but everybody needs it in some capacity. So we're gonna rebuild that. We wanna build functional strength. So increase the strength and then functional strength, right? Which is kind of that bridge to that reactive power. And so making sure that we're moving through ranges, we're connecting that to other pieces of the body. We're not just isolating the tendon, we're doing a lot of stuff together. And then if you do anything that's beyond just average life or recreation and you need some sport specific stuff, that's when you would add it in. So we've got some, I know we're coming up on time here. Load monitoring and safety guidelines, we've kind of touched on this the whole way through, but use pain as a guide, but understand that a painful tendon doesn't necessarily mean you can't load it. But there are some guidelines to it. So if you have pain still at 24 hours after activity, that's a guide that you need to back it off. Okay, a little bit of morning stiffness is okay, as long as it dissipates pretty quickly. And pain on initial loading, so if I get to the gym and I'm like, I'm kinda, doesn't feel great, but I get warmed up and it feels okay, that's all right, generally. I'm not gonna give a green flag to all of that, but that's, as a general guideline, that's usually okay. And chronic tendinopathy is a thing. And it's pain and function that persists over years and decades and sometimes never goes away. So you might just understand that as long as my pain stays at a 3 or a 4 out of 10, and functionally I have the capacity and the strength and all of that I need, we're okay, right? So understanding some pain is not a problem. If you are unsure, again, refer out, not our scope. Okay, yep, pain management. So, based on some of this, you're going to manage your loads. Remember, that was one of your roles in the beginning. Programming around pain, this is how you can adjust for it. So remember, surfaces, shoes, all of that stuff can affect your load. So the same actual load is gonna be different based on some of the other parameters. Volume, tempo, all of that stuff. Chronic tendinopathy and flare-ups. Let's see, any of this stuff. Yeah, this is all more, I wanted to make sure I threw this in here for you guys so you could see it. So here is kind of the overarching goals of what we're trying to do. So if we have someone who has a painful tendon of any kind, we're trying to minimize and control pain, not necessarily get rid of your symptoms, get their functional capacity up and ready for whatever they need to handle the loads and the volumes and speeds and everything else that they need for what they do. And then psychological readiness. I don't want to underscore how much this affects it. And hopefully you've at least learned about that a little bit, because that affects everything else as well. But I do want to highlight that because, again, same two people can have very different outcomes if this is a difference. So here are your takeaways. Load. Know your risk factors and use them. Screen to do that, right? Respect the tendon's timeline. Remember, it's really long. This is not a quick fix. This is something that will be an ongoing thing forever and ever and ever. Performance and durability need the same thing. So a lot of this comes from research about tendons that are injured, but performance needs the same stuff. So even if you have people who are not injured, the same things can apply, the same things can be utilized. Some can progress, obviously farther if they don't have the issues. Training needs to continue even when you're hurting. There are things you can implement and add the load, because remember, load is what the tendon needs even when it's injured, generally. And so continued training even with that, and then follow the recovery guidelines. So this is what I want you guys to think about doing, just like I've said. implement your screening protocols. Determine what that looks like for you and the people that you work with, or even for yourself. So determine what that is and then do that on an ongoing basis, on a regular basis. So you're monitoring it and then make your program adjustments based on that, based on the guidelines, all of that stuff. So thank you guys very much.